What makes you a candidate for a minimally invasive micro-parotid surgery? I'm Dr. Babak Larian from Center for Advanced Parotid and Facial Nerve Surgery. I'm going to discuss that today. Let's talk about the micro-parotidectomy itself. A traditional parotid surgery involved making an incision on the side of the face, in front of the ear, going behind the ear and coming into the neck. Now, some people have advanced that by putting the incision a little bit further closer to the ear and then going behind the ear and in the hairline, which is what we call a facelift incision. And that can work very well as well. But a micro-parotidectomy incision is when your incision is right by the earlobe and then in the groove that goes behind the ear. So a very small incision. Sometimes we make the incision a little bit longer here, right, going over the tragus, which is this little thing in front of the ear canal. The steps in the surgery involved first making the incision, raising the skin to let us get in there and be able to see the anatomy. Then first finding the nerve that goes right under the skin here to the earlobe and a circle around here. So this nerve is in charge of purely the sensation. It's called the greater auricular nerve, and is in charge of feeling in your earlobe and the skin of the side of the face and neck. Once we have that nerve identified, we can reposition it to be out of our way so we can get to the area of our tumor. In this case, the tumor seems to be here. Now, once we've retracted the skin, we found the greater auricular nerve, then we go and find the facial nerve, which comes out from the skull into the neck. Let me do it in black. Comes into the parotid gland and divides into two branches. The lower branch, which gives a branch to the neck and the lower lip. The upper branch, which gives a branch to the upper lip, smile muscles, eye, and eyebrow. All of that within the parotid gland. So our job is to find these branches and know where they're at, know the anatomy, get familiar with the anatomy and all these branching systems. And once we have that, then we can address the tumor. And the tumors, if it's here, sitting next to the lower division of the nerve, then we can separate the tumor and, when possible, get extra additional parotid tissue. We can't do that when it's sitting next to the nerve, but all the other areas will get additional parotid tissue. Once that's out, then the parotid gland, which looked like this originally, will have a portion of it missing. And when that portion is missing, we're gonna have to do a reconstruction for a couple of reasons. First, we don't wanna have an area that's sunken in on the side of the face. Also, if you don't do a reconstruction, the nerves that used to go to the saliva gland that instructed it to produce saliva when you were hungry or when you were eating can grow in your sweat glands in the skin and cause you to sweat. So by doing a reconstruction, we can prevent that from happening. And the reconstruction can be as simple as bringing the two edges of the parotid gland together and suturing it and putting a layer on top of it, which is all your natural tissues, or using a portion of this thick muscle in the neck, right, called the sternocleidomastoid. So this thick muscle goes from your skull all the way down to your clavicle. And we can use a portion of it to tuck it into this area, and the top of it is attached to the muscle itself, to the actual original muscle, and it has its own blood vessels, so we know it will survive. It's your tissue, and it's gonna fill in the defect. And that works very nicely. So it all depends on the size of the tumor that's removed, how much of a reconstruction we need to do. All of that can be done through this small incision, again, the micro-parotidectomy incision, which is just in front of the earlobe and then goes in behind the earlobe and the ear itself. The incision is always closed with plastic surgery sutures, which are under the surface. And so there's nothing to be removed. What determines if you're a candidate? Obviously the size of the tumor. So if you have a small tumor, less than, I would say, 6 centimeters, you are a candidate. If your tumor is much larger, then we may have to use the facelift approach, which is the incision that goes into the neck. And if your tumor is massive, comes down into the neck area or goes all the way to the front, we may have to use the traditional incision in order to be able to see the frontmost part of it or the lowestmost aspect of it. So my best advice would be to try to not let these tumors get that large so that you are a candidate. In terms of location, tumors can be in the back of the parotid gland. You can see that this whole thing is the parotid. They can be all the way in the front of the gland. It can be emanating from the front and going out. They can be in the upper, mid, or lower portion of the parotid gland. All of the yellow tumors that you see are tumors that can be removed through a micro-parotidectomy approach, through this small incision approach, right? This tumor that's in blue may be too far away. Now, I have removed tumors that are in the front in that area as well through the micro-parotidectomy approach, but I would have to see the patients and assess them myself to see if that's a possibility, right? But most tumors that are in the parotid gland proper and are less than 6 to 7 centimeters can be removed through the micro-parotidectomy approach. Now, tumors can also grow outwards. As you can see, this is a cross-section of someone's face. You can see the tooth sockets here going all the way across of the upper jaw. This is the parotid gland on the left side, the parotid gland on the right, and you can see this person has a large tumor that's growing outwards on the right side. And this patient, this is the parotid gland and the tumor. The tumor is growing inwards a little bit, so there's a portion of the parotid gland deep to it and a portion superficial to it. In this case, this is really interesting. The tumor is going entirely inwards and going towards the throat here, right? So the size of the tumor, the depth of the tumor affects what kind of an approach we take to remove tumors. Sometimes tumors that are deep, let's say if this tumor here was small, like this, and close to the throat, we could potentially remove it through the mouth, right? Some of these tumors we can remove just through a small incision going under the jaw when the tumor is deeper in the parotid gland, much deeper in the parotid gland, going towards the throat, right? So the location, the size, all of that matters in terms of you being a candidate for a micro-parotidectomy approach. Now, the type of tumor that you have also is a huge factor. So there are 15 different kinds of benign tumors, the most common type being pleomorphic adenoma. And the unfortunate thing about pleomorphic adenoma is that it has the potential of turning into a cancer. So it should be removed, especially if you're younger. And there's 20 different kinds of cancers that can occur in the parotid gland, right? So the type of tumor also dictates what we need to do, because if you have a type of cancer that is low grade, it's, let's say, small, and it doesn't spread to the lymph nodes, you still may be a candidate for a micro-parotidectomy approach. So this incision may be enough to allow us to see this tumor, find the branches of the facial nerve, and remove the tumor and an adequate amount of tissue around it to safely cure you of your cancer, all right? On the other hand, if the tumor that you have, or the cancer, if we know that you have a type of cancer that's either very large, very fixed to the surrounding tissue, meaning that it has roots all around, or it has spread to the lymph nodes, then we may have to use the bigger incision, which again, we'll try to hide in the face area as much as possible, and then try to get it into the skin crease so that we can have access to remove not only the tumor itself, but the lymph nodes that are in the surrounding area. So this person is not a candidate for a micro-parotidectomy approach, but smaller, lower aggressive cancers and most benign tumors allow you to be a candidate for a micro-parotidectomy approach. And the advantages of the small incision, besides having a smaller incision itself and having better cosmesis, is the fact that with a smaller incision, you have less dissection under the surface, you have less healing, less inflammation, less swelling, and a faster recovery. So most of my patients being from out of town, I do the surgery, they come the day before surgery, I see them, I assess them, I may even do an ultrasound in the office myself. The next day they have the surgery, they stay in town for 5 days after surgery. I see them several times during that time period to make sure they're healing well and everything's appropriate, and then they can go home. By the time they go home, everything is managed. All the potential risks and complications that can occur will occur in that 5 days, so I can manage them for you. And by the time they go home, the sutures which are under the surface will absorb on their own, and they don't need to see any other physicians. And they'll have my phone number, so they have access directly to my cell phone. So the patient and I can directly communicate, which really helps with healing. When patients feel that they're in a secure situation and they have access to the doctors, they heal better. Hopefully this is very helpful to you. I'm happy to answer any more questions you may have. You can reach us at parotidmd.com. Have a wonderful day and stay well.